Let's talk about hypertension. Hypertension is defined as lateral pressure that is exerted by a column of blood on the vessel measured in mm of Hg. BP is cardiac output into peripheral vascular resistance. Two most important determinants of the arterial pressure. Cardiac output will ultimately depend on stroke volume and heart rate. Peripheral resistance will depend on the vascular structure and the vascular function. So all these things will ultimately determine the blood pressure of the patient. Coming to the RAS system, renin will convert angiotensin into angiotensin 1, which will get converted to angiotensin 2 in the presence of ACE, which ACE will convert bradykinin into inactive peptides. Angiotensin 2 will act on angiotensin 1 receptor and angiotensin 2 receptor. Angiotensin 1 receptor is a major receptor responsible for vasoconstriction. It will ultimately activate aldosterone. Primary hypertension, it accounts to 90 to 95% of the cases. Environmental factors, strongest independent risk factor is obesity. Diet is high in sodium but low in potassium, calcium and magnesium. Stress, non-proven is alcohol consumption, low vitamin D, high fructose diet and lack of exercise. Genetic factors, the parent with hypertension, the risk is 10 to 15%. Both parents having hypertension, the risk is 30 to 40%. And gene is alpha-adducin gene. Secondary hypertension accounts for 5 to 10% of the all cases. First one is renal parenchymal diseases, renal cyst including polycystic kidney disease, renal tumors including renin secreting tumors and obstructive uropathy. Renovascular is atherosclerotic and fibromuscular dysplasia. Adrenal, its primary high aldosteronism, Cushing's syndrome, 17 alpha hydroxylase deficiency, 11 beta hydroxylase deficiency, 11 hydroxysteroid dehydrogenase deficiency, that is licorice ingestion, and pheochromocytoma. Other causes are aortic coarctation, obstructive sleep apnea, preeclampsia and eclampsia. Neurogenic causes are psychogenic, Dankefleck syndrome, familial dysautonomia, polyneuritis, acute porphyria, lead poisoning, acute increased intracranial pressure, acute spinal cord section. Miscellaneous endocrine factors are hypothyroidism, hyperthyroidism, hypercalcemia, and acromegaly. Medications, with certain medications which cause hypertension, most common are high-dose estrogen, adrenal steroids, decongestants, appetite suppressants, cyclosporine, tricyclic antidepressants, monoamine oxidase inhibitors, erythropoietin, NSAIDs, and anti-inflammatory agents, and cocaine. Monogenic forms of secondary hypertension are Liddle syndrome, apparent mineralocorticoid excess, glucocorticoid remediable aldosteronism, and Gordon syndrome. So these are an important MCQ. What are the advantages of 24-hour BP monitoring, ambulatory BP monitoring? White coat and masked hypertension can be detected. Now, what is white coat hypertension? White coat hypertension is when a patient presents to a clinic due to anxiety. The measurement of BP in the clinic are always high compared to when throughout the day. So it will lead to a false diagnosis of hypertension when actually the baseline BP is normal. Masked hypertension is exactly opposite of white coat hypertension. Usually the BP is normal or low in case of when you measure it in the clinic, but throughout the day it is substantially high. Absence of nocturnal dipping can be diagnosed. Increased cardiovascular mortality in diabetes mellitus patients. Higher prevalence of nocturnal dipping being absent in patients with CKD. Higher ambulatory BP variability in patients with decreased EGFR, decline in EGFR in non-dippers. Non-dipping is associated with increased risk of ESRD and high mortality. 10% higher nocturnal dipping is associated with decreased risk of CKD and lower annual rate of EGFR decline. ABPM predicts both renal and cardiovascular outcomes. Episodic hypertension, postural hypertension, or hypotension, both can be detected. Coming to white coat hypertension, account for 30 to 40% of the people with elevated or office BP. It is more common with increasing age in women and in non-smokers. A significant white coat effect can be seen at all grades of hypertension, including resistant hypertension, but prevalence of white coat hypertension is greatest in grade 1 hypertension. HMOD is less prevalent. Risk of cardiovascular events is also lower than that is sustained hypertension. Masked hypertension found approximately in 15% of the patients with normal office BP. I'm sorry for the color. The prevalence is greater in younger people, men, smokers, and those with higher levels of physical activity, alcohol consumption, anxiety and job stress, obesity, diabetes, CKD, family history of hypertension, and high normal office BP are associated with increased prevalence of masked hypertension. The risk of cardiovascular events is systemically greater in masked hypertension, and the risk of renal events and diabetes, especially when the BP elevation occurs during night. When BP is less than 120/80, optimal BP, repeat BP at least every 5 years. Normal BP, that is between 120 to 129 and 80 to 84. Repeat blood pressure at least every 3 years. High normal BP, that is 130 to 139 divided by 85/89. Consider masked hypertension. Repeat BP at least annually. Out of office BP measurement or ambulatory BP measurement. For hypertension, BP is greater than 140/90. Use either to confirm the diagnosis. Repeated visits for office BP measurement, out of office BP measurement, that is ambulatory BP monitoring. Indications. A laboratory test for initial evaluation. Renal system, it is microscopic urine analysis, albumin excretion, serum BUN and or creatinine, exocrine, it is serum sodium, potassium, calcium and TSH. Metabolic, it is fasting blood glucose, total cholesterol, HDL and LDL, often computed, cholesterol and triglycerides. Other is hematocrit and ECG. High normal BP, 130 to 139 by 85 to 89 millimeters of mercury. You give lifestyle advice. Consider drug treatment in very high risk patients with CVD, especially CAD. Grade 1 hypertension is BP when 140 to 159 and 90 to 99 millimeters of mercury. You will give lifestyle advice. Immediate drug treatment in high risk or very high risk patients with CVD, renal disease or HMOD. Drug treatment in low moderate risk patients without CVD, renal disease or HMOD after 3 to 6 months of lifestyle intervention if BP not controlled. Grade 2 hypertension is between 160 to 179 and 100 to 109 millimeters of mercury. You will give lifestyle advice. Immediate drug treatment in all patients. Aim for BP control within the next 3 months. Grade 3 hypertension when BP is more than 180 by 110. Give lifestyle advice. Immediate drug treatment in all patients. Aim for BP control within the next 3 months. Lifestyle modification to manage hypertension. Weight reduction, that is attain and maintain BMI less than 25. Dietary salt reduction less than 6 gram NaCl per day. App dash type dietary plan. Diet rich in fruits, vegetables, low fat dairy products with reduced content of saturated and total fat. Moderation of alcohol consumption. For those who drink alcohol, consume less than 2 drinks per day in men and less than 1 drink per day in women. Physical activity, regular aerobic activity, brisk walking for 30 minutes per day. Antihypertensive drugs like diuretics, thiazide like hydrochlorothiazide, chlorothalidone and indapamide, high ceiling like furosemide, aldosterone antagonist like spironolactone, and eplerenone. Renin-angiotensin system inhibitors are ACE inhibitors like captopril, enalapril, lisinopril, perindopril, ramipril. Angiotensin receptor blockers is losartan, candesartan, valsartan, telmisartan, olmesartan. Direct renin inhibitors is aliskiren. Alpha adrenergic blockers, sympathetic inhibitors are beta blockers like propranolol, metoprolol, atenolol. Alpha beta blockers is labetalol and carvedilol. Alpha adrenergic blockers are prazosin, terazosin, phenytolamine. Central sympatholytics are clonidine and methyl dopa. So these are all the classifications of antihypertensive drugs. Antihypertensive drugs like calcium channel blockers, Phenylalkylamine is verapamil. Benzothiazine Zepin is diltiazem. Dihydropyridine is nifedipine, felodipine, amlodipine, cilnidipine. Arteriolar dilators are hydralazine and minoxidil. Arteriolar and venodilators are sodium nitroprusside. For uncomplicated hypertension, we start with ACE inhibitors or ARB plus calcium channel blocker or diuretic. ACE inhibitors or ARB plus calcium channel plus diuretic in step 2. In step 3, we add spironolactone or other diuretic and alpha blocker. Beta blockers at any treatment step when there is specific indication for the use, example heart failure, angina, post-MI, atrial fibrillation, younger women with or planning pregnancy. In patients with coronary artery disease, initial therapy is dual combination, that is ACE inhibitors or ARB plus beta blocker or calcium channel blocker plus diuretic or beta blocker plus diuretic. Consider monotherapy, grade 1 hypertension, systolic BP less than 150 or very old or failure patients. Step 2 is triple combination of the above. Consider initiating therapy when systolic BP is more than 130 mmHg in these very high risk patients with established coronary vascular disease. Step 3 is add spironolactone or other drug 25 to 50 GOD or other diuretic alpha blocker or beta blocker. Consider to refer to a specialist center for further evaluation. In case of patients of CKD, we will initially start with ACE inhibitors or ARBs plus CCB or ACE inhibitors plus ARB plus loop diuretic. Beta blockers, consider beta blockers at any treatment step when there is a specific indication for the use like heart failure, angina, post-MI, atrial fibrillation or younger women with or planning pregnancy. Step 2 is triple combination. You add a calcium channel blocker plus loop diuretic. Step 3 is triple therapy is resistant hypertension. You add spironolactone 25 to 50 mg per OD or other diuretic alpha blocker or beta blocker. With heart failure, initial therapy is ACE inhibitors or ARB plus diuretic plus beta blocker. ACE inhibitors are when it is step 2, it is you add a beta blocker and MRA to that. Targets of blood pressure to be maintained is in less than 65 years, it is less than 130/80, greater than 65 years is less than 140/90, but not greater than 120/70. Systolic blood pressure is more important than diastolic blood pressure. Accelerated hypertension is hypertensive emergency with new onset of changes in fundus, that is flame-shaped hemorrhages or cotton wool hemorrhages and hard exudates in fundoscopy. Malignant hypertension is accelerated hypertension plus papilloedema. Resistant hypertension, 3 drugs with BP greater than 40 or 90 and 4 drugs with BP less than 140/90.